All right, here we have a very nice hip dissection by Dr. Trinan. Let's see, we can see in here, here's some of the IT band, I think with some of the gluteal, gluteal tendon feeding into it. We've probably got this maybe some IT band or just some fascia lata here. This is probably a bit of rectus femoris here, but what I do know for sure is that we have a very nice cut in the ischiofemoral ligament back here. This is probably maybe some hamstring, maybe coming off the ischial tuberosity, but nice cut into the hip joint capsule. Let's see what we can hear with this. That, ladies and gentlemen, that sucking sound is when the negative pressure inside the hip capsule becomes equilibrated to the atmospheric pressure as a result of a posterior dislocation. So taking the femur up into flexion, cut in the ischiofemoral ligament, and this is what you get. So let's see if Dr. T is going to try to replicate this again. So you don't get as much of a pop sound, sucking sound on that. It's because it's like opening a pop can. You can't really do it a second time. That was more of a wet sound. So we've got maybe a bit of wear here on some of the head of the femur, but this isn't where we would expect to see a lot of wear. That would be coming up here in this view. Let's see, a good stopping spot here. Here we go. So the ligamentum teres has been cut right in here, and in the middle we'd expect to see the foveal artery. But if we look inside here, we can see the ligamentum teres with I think this is a bit of the foveal artery just sitting out right in here. The ligamentum teres is coming up through a space spanned by the transverse acetabular ligament. We can't see it, but it would be deep here to where where the arrow is pointing. We can nicely see the lunate surface of the acetabulum. This is a right leg, so if we could follow that lunate surface all the way around and look in here, right, we would probably see in this region of that lunate surface maybe a little bit of wear, because that's the greatest contact pressure between the head of the femur and the acetabulum. So maybe some wear up in here. And now we're going to move on to a disarticulated patellofemoral joint. We've obviously cracked into the joint capsule because we can see the tibial plateau along with the condyles of the femur. Here we have some of the pes anserine group. So this would be sartorius right here and gracilis coming in here. The patellar tendon has been cut. Some people will refer to this as the patellar ligament, saying it's connecting the patella with the tibia, and they'd say that the patellar tendon is the part up above here. I also think it's okay to say to call this the patellar tendon if you think of the patella as a sesamoid bone that is fully encased within a tendon. So either way. Let's see, so as we look underneath here, what do you see? So we've got for sure some wear in here. Now this is a right knee, so this would be on the lateral side of the patella here. Maybe some osteophytes in here. As I look on this articular surface, I'm not seeing too much wear right in here. Maybe have an area of wear right in here. Got an interesting sort of drop right here on the articular cartilage of the medial condyle. That could be part of just the normal structure. I don't know that necessarily means there's wear, but we'll take a look here in a moment. We're definitely down to the bone right in here. So if we were going to look for articularis genu, it would not be down here. We can see the yellowish here has been cut, so it says that we've cut the capsule away beyond it. But so it is worth looking though under here to see if articularis genu is there. The other thing to think about here with this wear pattern is to ask, what kind of position or loading might cause that. So let's harken back here to the lecture and take a look. This is the underside of the patella. Now this is the left patella. I think this is left. This is not the right one like we're looking at, but we can see here, contact at about 20 degrees of flexion, 60, 90 degrees, and then as we get into more flexion here, we're up on the medial and lateral facets. So from my perspective, it's probably about the midline here, middle of the patella, we're seeing it. So we're looking at some 60-degree kind of contact. Okay, so maybe person was sitting for a bit too long in knee flexion, about 90-ish degrees, maybe a little bit more extension than 90. Okay. Oh, there it is. Look at that. Good job, Dr. T. So I think this would be the underside of the articularis genu muscle. See a little bit of muscle fiber in here. Might see a little bit more if you came more proximal, but sometimes it's not super muscular muscle. So that was really sweet dissection there. Look at the condyles now. All right, so definitely have some wear here in the middle, which is consistent with what you'd get if you're sitting at around 90 degrees or so. As you look over the surface, you could see sort of varying levels of opaqueness. Looks like really here on the lateral condyle, there's some wear down in here. Maybe some over here on this side too. Anterior cruciate ligament. Here's the back part, the most anterior part of the posterior cruciate ligament. The posterior cruciate ligament attaches more anterior on the femoral condyle, more posterior on the tibia, and then it's the opposite for the ACL. Definitely got some lateral condyle wear there. Okay, so we've got some meniscus here, but not a whole lot left. Right, a lot of this is just going to be on bone here. So not much meniscus there. You can see here how tightly the MCL is integrated in with the joint capsule. It's been cut away, but it attaches, that meniscus attaches right to that capsule there. And then over here, boy, this looks like a meniscus tear. This could be a lateral meniscus tear. This should be, I don't know if this is part of the anterior portion. It looks like it's part of the anterior portion here that just got torn away. See how jaggy this edge is. So looks like maybe we had a meniscus tear here. So this is part of meniscus here, and then this right in here is part of the coronary ligament, which would normally be pulling itself over the meniscus to try to tack it down. Well, that's a good sized tear there. better view of the MCL. There's the ACL. Wow, we're going to really crank on that now. Okay, look down in here. So we could have some meniscus tearing in here. And then this back in here. Again, I think this edge right here is part of this edge right here. Either that or it's the back part of the lateral meniscus. But here you can see a little bit nicer. Here's the ACL and the PCL. Oh, I do want to show. Oh. So right in here, right, definitely got some cartilage wear right there on the medial meniscus. And here we've got a really nice transtibial cut. So think, what are we looking at here? Right, this is a left foot. We're looking at the lateral side of the left foot. So all of these muscles in here would be anterior compartment muscles. You can see the extensor digitorum longus tendons. You know, I'm asking myself, is the fibularis tertius in here? This is the shaft of 5. I'm not sure that I see a tendon coming down into here. If we look over here, right, this is the lateral compartment, and we can clearly see this tendon right in here would be the fibularis longus, because it's diving under the lateral longitudinal arch, and then this tendon coming right in here, attaching to the base of 5 here, would be the fibularis brevis. Look at how nice and beefy the intrinsic extensors of the toes are. Rotate medial, there's TA. You can see TA very nice. Extensor hallucis longus. I want you to appreciate how hard this is for Dr. T. She's trying to hold and dissect with one hand while filming with the other. So there goes, let's see, that was TA. There's extensor hallucis longus. There's extensor digitorum longus. And now, right, we get a really pretty view of the intrinsic toe extensors. This right along in here is the extensor hallucis brevis. The rest of these would be the extensor digitorum brevis tendons. So these anterior compartment muscles have been removed. Here we can see the interosseous membrane. So now we're going to the medial side, and you'll keep in mind that anything we see here in the medial view is coming from the posterior compartment. So we have obviously the Achilles tendon here. And if you look close, this tendon right here, this is tibialis posterior. And then this would be the flexor hallucis longus next. Remember, or I'm sorry, flexor digitorum longus. So Tom, tibialis posterior, Dick, flexor digitorum longus. Okay, so we have removed the superficial subcompartment of the posterior compartment. So now we can see in these deeper, deep compartment muscles here in the posterior compartment. So tibialis posterior, flexor digitorum longus. We've got artery and nerve. And then this is flexor hallucis longus right along here. One of the fun things, if you get a chance to get into lab now that you have a transtibial cut, is to try to see the difference in joint play that you get, particularly with the midfoot. You're going to find a release in some of the tension of the midfoot when you make a transtibial cut, which reinforces how midfoot motion is influenced by these leg muscles. All right. Great job, Dr. T. Thanks.